Hello, everyone. Hope that you're doing well. Just to kind of recap some of the things that we went over in class, being that this was our first day of cardiopulmonary anatomy and physiology, I just want to stress the importance of understanding the overall route of blood uh, through the heart and essentially through the body. I think it's important as we're going to move forward with pathophysiology. I know you're learning that concurrently with anatomy and physiology. But nonetheless, it's got, I think if you can understand and appreciate how something normally works, that's going to make it a little bit easier to understand what's going on if something's not working right. And I think a super important thing to really understand and make sure that you know is how blood is supposed to move throughout the heart. When you get into and we'll refer to that as adult circulation. When you get to your neonatal pediatric class, you're going to learn about fetal circulation and how blood flows through the body in utero. But even understanding the adult circulation route will make that make a little bit better sense when we start to talk about things and the oxygenated route, the deoxygenated route, the where blood goes when it leaves the heart, so forth, what side of the heart serves which purpose. So I definitely think we should review those items. So we know that the heart sits in the center, pretty much in the center of the chest, behind the sternum. It's enclosed in the rib cage into the thoracic cavity. Uh, Roughly, heart's about the size of your fist, and it is going to sit behind your sternum, kind of off to the left, just a little bit, with the apex pointing toward the left. So, if you're talking about, go back to your introductory class in respiratory therapy, where we talk about inspection, palpation, percussion, and auscultation. Uh, get into palpating your intercostal space and so forth, and knowing your anatomical landmarks. So knowing that our sternum lies here, and there's three parts of the sternum. We reviewed those yesterday. You have the manubrium, you have the sternal body, and then there's the xiphoid process. And remember, we talked about hand placement during CPR. You want to make sure that you're not too low. On the sternum, because you could potentially break that xiphoid process, and then that could potentially cause a pneumothorax or cause some other issues. And then the apex of the heart, we said, is off center to a little bit. So really, if you place your hand on your chest in about the fifth intercostal space, mid clavicular, so find the clavicle bone and go in the middle of it all the way down, that's where you're going to feel that point of maximal impulse. You may be able to feel a little bit better if you have the patient lean forward, or if you lean yourself forward, or even lie down on that. Uh, but that's the point of maximal impulse, because the apex of the heart, if you'll follow my cursors, this area here, the ventricles are there, and specifically the right ventricle is strong, but the left ventricle is a little bit stronger. Notice the difference in muscle mass. So you're a little bit thinner ventricular wall as opposed to a little bit thicker ventricular wall. Maybe it's a terrible analogy, but I did discuss this in class yesterday as well. Uh, I always kind of refer. So if you've seen the latest rendition of Baywatch, where you got Zac Efron and The Rock, both phenomenal shape, both really chiseled. However, one has probably lifted a little bit heavier. Maybe genetics plays a role in that too. But so if we were looking at the right heart versus the left heart, the right heart would be more along the lines of, say, a Zac Efron build, as opposed to where the left heart would be more along the lines of a Dwayne Johnson build. So we can appreciate that too. We want to look at the heart as being a pump. We know that the heart's job is to move blood through the body, to move blood through both the pulmonary circuit and through systemic circuit. When I talk about pulmonary circuit, I'm talking about the blood vessels that go through the lungs. When I talk about the systemic circuit, I'm talking about the blood vessels that go out to the rest of the body. And this has to happen every time that the heart beats. And we know that a normal heart rate is anywhere between 60 to 100 beats per minute. Anything above that is going to be considered tachycardia. So a heart rate over 100 beats per minute would be considered tachycardia, fast heart rate. Anything less than 60 would be considered bradycardia, or a slow heart rate. So normal heart rate, 60 to 100 beats per minute. And that's important too, because we'll probably touch on the electrophysiology just a little bit after we get done with this. But remember, I told you as we're going through the heart, it's important to be able to know that there's four chambers in the heart. You've got two atria and two ventricles. Those atria are going to sit on top of the ventricles. So if my right hand or say are the atria, my left hand are the ventricles. When those things pump, they should pump in a coordinated fashion or should contract in a coordinated fashion. For the atria, allow the blood going down to the ventricles. Ventricles are going to fill, and then when they squeeze, they're going to pump blood in their respective circuits. Uh, we talked about how blood flows from the atria to the ventricles and then to the ventricles up into the respective circuits. So do recall that as well. Um, when we talk, I said the easiest way to remember is kind of think about being on a journey, if you will, and that's kind of how we started the class out yesterday, and we did this a few times just to kind of um, make sure that you understand the concepts. But we said that the heart is a forward pumping organ, and its job is to continue to circulate blood, keep it moving in a forward direction. And we'll talk about the valves and stuff and how those help prevent some of the backflow of blood that might cause a murmur, regurgitation, um, or things of that like. You can split the heart up into two different sides. So you have a right atrium, which is here, and a right ventricle, which is here. Now, mind you, this heart on the screen is how it would sit in your chest. So although my cursor, if you're looking at your computer screen, my cursor is moving on the left-hand side of the screen when I'm talking about the right side of the heart. And we've got to get used to orienting ourselves in such a way to know that this is basically like we're looking at someone else's body standing facing us. So their right is obviously our left there, and vice versa. So yes, this is the right atrium, this is the right ventricle, this would be the left atrium, and this would be the left ventricle. So we have two different sides. We have a right side of the heart, a left side of the heart. Right side of the heart is responsible for moving blood forward into the lungs. It's also important to understand which side of the heart receives it, where it receives its blood supply. So the right side of the heart is responsible for moving blood into the pulmonary circuit or into pulmonary circulation or sending blood to the lungs. Where does the right heart receive its blood supply from? It receives its blood supply from the body. So blood is returning back to the right heart after it's been out to the body, so that it can go through the pulmonary circuit to drop off its CO2, be replenished with oxygen, and then return itself to the left side of the heart, so that the left side of the heart can now move its blood forward out to the rest of the body. So where does the left side of the heart receive its blood supply from? The lungs. And this happens every time that the heart contracts, and that heart contracts, remember, 60 to 100 times per minute, and then sometimes much faster, sometimes a little bit slower, depending upon if you've taken any medicines, or some people just naturally have a little bit slower heart rate as well. But that being said, after the blood has left the left side of the heart and it's gone out to the body, it's carrying all this oxygen-rich blood to the body so that the tissues and other organ systems within the body can be replenished with oxygen, because we need oxygen to live. Absolutely have to have it. Uh, and the byproduct, that there's going to be an exchange. So if I'm taking oxygen somewhere, I'm going to drop the oxygen off. I'm going to pick something up. That something that I'm picking up is carbon dioxide. So I'm going to take that back with me, so that when I get back to the right side of the heart and I go through pulmonary circulation, I get to that capillary bed within the lungs. Then I can uh, engage in the exchange of putting off CO2 into the lungs, so that can be exhaled out. When we breathe out CO2 and water. And then and we breathe in. Remember, we talked about the composition of room air being 21% oxygen, talked about 78, 79% nitrogen with a small percentage of other trace gases. We also provided you the scenario where breathing in 100% oxygen, how that might be bad, because oxygen does participate in gas exchange. So if you got an alveolus that's 100% full of oxygen, all of that oxygen could go into the bloodstream, and that would leave that alveolus closed down, atelectatic, and then that could cause other atelectasis to assume. And it's called absorptive atelectasis. So we did talk about how 100% oxygen can be bad to breathe in. But nonetheless, let's focus on the blood flow. There was a lot of good conversation that we had yesterday, a lot of things to build upon. My goal is to keep these things 10 minutes, 10 to 15 minutes or less, and as you all understand, there's a massive amount of stuff to talk about. So sometimes it's easy to to go overtime with that. So we are going to focus on blood flow, and if time allows, we'll talk briefly about the electrophysiology of the heart. Maybe I'll do another recording on the electrophysiology of the heart as we go through there. But like I said, I want everyone to pretend that we're on a journey. We are backpacking, or we're a red blood cell, and we're making our way through the body and making our way through the heart. And we want to talk about and identify the anatomical structures as we get there. And I do appreciate this graphic that I'm utilizing. I pulled it off the website that you can see there at the bottom. Uh, so, but nonetheless, I thought it was good for me to be able to utilize as I'm teaching you all here. So, blood has to come, deoxygenated blood, after it's been out to the body and it's picked up CO2 and it's dropped off the oxygen at the body, it's picked up the CO2. It's got to come back to the heart so it can be recycled back around. So blood flow through the heart is really going to be a right to left situation. I know that when we write or read, we tend to go left to right, but when we're talking about blood flow in the heart, it really is a right to left situation. So I'm going to begin on the right side of the heart. So blood returns back to the right atrium by way of that superior vena cava, which you see here, and the inferior vena cava you see here. So these are going to drain blood back, or basically deliver blood, deoxygenated blood, and that's why we're going to utilize blue and red. Blue is going to denote deoxygenated blood, red will denote oxygenated blood. Uh, so blood gets returned from the body by way, and let me see if I can make that just a little bit thicker so it's easier to see. Blood gets returned back to the body by way of your superior vena cava and your inferior vena cava. And that blood gets into the right atrium. So that blood hangs out in the right atrium. And remember, we also talked about some terms such as preload and afterload. So the volume of blood that makes it back to the heart during the diastolic phase. So systole and diastole are also things we talked about. The systolic phase is the actual pumping of the heart. The diastolic phase is when it's not pumping and it's relaxed, and those ventricles and or atria are filling back up with blood, and that volume is called preload. And then anything that would impede, uh, increase the workload that the heart has to pump against, essentially, is going to be afterload. So afterload is an increase in resistance, or the resistance in which the heart has to pump against. So remember, that can be vascular issues, that can be valvular issues. We talked about those, and we'll cover those again in some patho things moving forward. But we've got deoxygenated blood, hence the color blue, and we're in the right atrium. From the right atrium, we're going to encounter our first structure, and that's going to be on the right side. This atrioventricular, there's two atrioventricular valves. We're going to talk about the first one here. This is the tricuspid valve. So the tricuspid valve's on the right side of the heart, so that blood's going to make its way through the tricuspid valve. After the atria contract, that blood's going down to the tricuspid valve, through the tricuspid valve into the right ventricle. That deoxygenated blood's now going to fill the right ventricle. And then when the ventricle contracts, that blood's now going to go up through and encounter its next structure, which is the pulmonic semilunar valve. Goes through the pulmonic semilunar valve up into the pulmonary arteries. And once it gets through the pulmonary arteries, that blood is going to make it out to the lungs. So it's going to go to the lungs, and I'll just kind of connect those together. It'll go to the lungs, where it's going to get down to the capillary beds. The capillary beds are going to surround those little structures that we talked about earlier called your alveoli. That's where gas exchange is going to take place. So where you have the air that we breathe in, the oxygen goes into the bloodstream, and then the CO2 can come out. So you've got CO2 in the lungs, and oxygen within the blood. So we want to have an exchange there. So we have the deoxygenated blood through the capillary network that occur throughout all the millions of alveoli that you have within your body. So that gas exchange takes place. CO2 comes out of the blood and into the lungs, so that when you exhale, you can breathe that CO2 out. And the air that you have breathed into your lungs, the 21% room air that you've breathed, 21% oxygen room air that you've breathed into your lungs, has the oxygen that is uh, now ready for its return back to the left side of the heart. So once we've gone through the capillary networks and we've done the exchange, now notice the difference in color. Difference in color lets us know that that is some oxygen-rich blood. That oxygen-rich blood is now going to go back through the pulmonary veins. Through the pulmonary veins, Now it's going to the left heart. So the left heart is now the supplier of blood uh, from the or the lungs are the supplier of the blood to the left heart. So from the pulmonary veins, that blood's going to go into the left atrium, fill the left atrium. Upon contraction of the left atrium, that blood's going to encounter its next structure, where atrioventricular valve, where we're now going to encounter the bicuspid or mitral valve. That bicuspid or mitral valve allows the passage of blood from the left atrium into the left ventricle. That left ventricle now begins to fill with blood, and upon contraction of that the left ventricle, that blood's going to go up through the aortic simular valve, which is this valve right here, into the aorta, and then this blood is going to go through the aorta, so that aorta is going to continue down, and then that's going to give blood to the lower part of the body. And then you've got these different trunks or sections of the aorta that will take blood to the shoulders, the head, and so forth. But essentially, for all intents and purposes, once the blood goes through the aorta, it is going out to the rest of the body. So it goes to the rest of the body, and then from the rest of the body, that blood has been, it's oxygenated blood. It delivers oxygen to the tissues where it needs. So this is our arterial system, which is full of oxygen-rich blood. And then our veins will now basically collect that deoxygenated blood and now take it back to the heart through our veins and vena cava, our superior and inferior vena cava, for this cycle to happen and occur every time that the heart beats. Um, so it's going to be super important to make sure that you can name the anatomical structure of the heart and also pretend that you are a red blood cell and talk your way through the heart so that you know the journey through the heart. Um, and also probably add in there a little bit of the gas exchange where we talk about our internal and external respiration that can take place there. Um, I've got a couple more minutes, so I had drawn in a set of lungs to hopefully help make that make a little bit better sense. And we'll show you right briefly. Let me clear all of this drawing, and we'll advance to the next slide briefly, just because I found this when I was looking for other items. It's a pretty good diagram that shows the cyclical flow of blood. It happens every time that the heart's beating, and I had to draw it right side and left side, so one at a time. But it's important to understand that when the atria contract, both atria are contracting at the same time, or close to the same time. When the ventricles are contracting, they're all contracting in a very coordinated event. So, like I'd said, if the atria sit on top, the ventricles sit on bottom. When they contract, it should be a very coordinated event so that you've got blood going from the atria into the ventricles and then from the ventricles into their respective circuits. Right side of the heart receives its blood flow from the body, right side of the heart sends its blood flow through the pulmonary circuit. Left side of the heart receives its blood flow, its fresh oxygenated blood flow to the from the lungs or from the pulmonary circuit, and then the left heart is responsible for moving that oxygenated blood out to the rest of the body. We also talked about this intraatrial septum and intraventricular septum that we had discussed. And basically, it separates the right side of those. The purpose of those septums is to separate the right side of the heart from the left side of the heart. And this will get a little bit more into our pathology when we get there. But if you were to have an atrial septal defect or a ventricular septal defect, an ASD or a VSD, and we'll cover a significant one up here from the atria when we talk about our neonatal pediatric stuff, and we get into a PFO, fetal circulation, things of those. If those holes don't close, or if those holes are there, you can see why that would be problematic for the patient, because you have the right side of the heart that's supposed to carry deoxygenated blood to the lungs. Lungs are supposed to carry or the pulmonary veins are supposed to carry oxygenated blood from the lungs back to the left heart. So you have the oxygenated blood on the left side of the heart, deoxygenated blood on the right side of the heart. So if there were a hole in between the either the ventricles or either the atria, then that would be super problematic, because now you're going to have deoxygenated blood mixing with oxygenated blood, and then it's going to lessen the amount of oxygen that's supposed to be going out to the rest of the body. So that's where you will see some of those clinical manifestations, clinical signs and symptoms, so forth, of patients being on the hypoxemic side, whether it's cyanosis or other clinical manifestations that could have come along with that. So it is important to understand the arteries carry oxygenated blood in the body. Veins carry deoxygenated blood in the body. The only place where that's different is right here attached to the heart. The pulmonary arteries carry deoxygenated blood. the pulmonary veins carry oxygenated blood. You're going to want to remember that as well. Uh, so I think that's probably pretty good when we talk about blood flow. I was going to try to work in the electrophysiology of the heart, but getting a little short on time. So I'll do another mini video that'll talk about the electrical activity of the heart, because remember, with the heart you have electrical activity and you have mechanical activity, and it's important to understand the two of those as well, because it's possible for the electrical activity to occur but not cause a mechanical activity. But pretty much you're not going to have mechanical activity without the electrical activity unless you're mainly doing chest compressions on somebody. Okay, so I'll be quiet. Thank you all for your time today, and I'll try to get the electrophysiology video done as well and get that all sent out to you. Thank you again. Have a good day.